how should I treat isolated ostial LAD or ostial circumflex. Bifurcation continuum, this is the mode 7, and we left for the last webinar this year the most challenging question to address. My name is Goran Stankovic. I'm an interventional cardiologist from Belgrade, Serbia, and I have great pleasure to introduce fantastic faculty today, Professor Maciej Lesiak from Poznan, Poland, and Professor Francesco Burzotta from Rome, Italy. Every bifurcation session anywhere in the world has at least one question: how should I treat isolated ostial circ 001? So for today's webinar, we have the following learning objectives: to learn how to evaluate left main 010 isolated LAD or 001 isolated ostial circ bifurcation lesions in terms of morphology and clinical relevance, to understand different treatment strategies for isolated ostial LAD or ostial circ, and to learn the role of imaging for the assessment and treatment of ostial LAD and ostial circ stent failure. And we will start with case number 1, and I would like to ask Professor Lesiak to present his case.
Thank you, Goran. So let me show my case. This is a 55-year-old female admitted to a regional hospital with recurrent chest pain at minimal exertion and sometimes at rest. Active lady, not very old, with normal cognitive function. As for the risk factors, hypertension and dyslipidemia. On the ECG, a sinus rhythm, 85 beats per minute, and ST depression with some negative T waves at precordial leads could have been observed. On echo, normal LV function, troponin I slightly elevated. So the doctors put diagnosis of non-ST elevation MI, and the patient was sent directly to the cath lab. So that's the angiogram. So this is baseline angiography. So no disease, significant disease in the right coronary artery. But in the left coronary artery, you can appreciate that there is something wrong with the ostial LAD. And let me show you at the still frames more clearly. So there is some haziness and ostial narrowing of the LAD that was assumed to be a culprit and the reason of patient's symptoms.
Yeah, this is a great example. We see it frequently in the cath lab, and there is always question: should we try to be very precise, or we do crossover stenting, then we pot and kiss? That's, I think, unanswered question so far. We have already question from Amar Imran. I ask about Szabo technique. Is it still used? And what is the disadvantage of this technique? So whoever would like to address, but I like to ask Francesco what would be his strategy. In my cath lab, in general, we recommend crossover as a standard approach to isolated ostial LAD. But what is your practice, Francesco?
So, Goran, I think that this kind of lesions are still the subgroup of cases in which we have no final answer. We try, to adjust case by case. The problem with the Szabo's technique, that for people that doesn't know, is a technique in which you decrimp a little bit the stent to mount the side branch wire across the very proximal part of the stent, and should this technique facilitate the precise ostial stenting of the branch you are intended to do. So with this technique, the problem is that you may sometimes be able to do this, but even in some bench tests, there is a study assessing this, you are not 100% sure about the fact that it is really landing where you think that should land. So according to this, most of the time also in Rome, we practice crossover stenting. For sure, this means that you are doing a probably more complex procedure, more dilations and so on, but probably is a flow of a procedure that is a little bit more predictable in my mind.
Yeah, thanks, Francesco. Maciej, what your colleague did when they saw this angiogram?
Okay, so we could go back to my presentation. Yes, so they decided, perhaps because the patient was unstable, so they decided a very simple strategy, just the Ostial LAD stenting with direct delivery and deployment of a stent. So they chose 4/0/15 drug-eluting stent. So you see the still frame, and they believe that they are just right at the ostium of the LAD. And actually, they were very successful. So you can appreciate a very nice result of the early result of the procedure. The patient became asymptomatic, and the patient was released just a few days after, without any further sequels. So this strategy proved to be very, very successful in this acute phase.
Yeah, Dr. Pasca is asking, should we do IFR or FFR to assess functional significance before we proceed with PCI? I mean, anyone can answer. It's your practice.
Yeah, as in any lesion, with any lesion, if we are in doubt, we should do this. But keep in mind that if we have symptomatic patient and single vessel disease, which looks significant angiographically, then of course we don't use FFR. And the second thing is that we are in a setting of acute coronary syndrome. And again, it's easy because we have just one lesion in one vessel. So I don't think any place for physiology here in this case, at least to make a decision of stenting.
Yeah, Francesco, Bogdan Janusz is asking how to deal with left main trifurcation and only ostial LAD or ostial circ involved. I know that you are really working a lot in bench testing, also in register on trifurcation. What would you advise our colleague from Poland?
So I'm sorry to say that the bifurcation interventions are almost always imperfect due to the fact that we try to adjust with a tubular stent a lesion a vessel that is basically complex with different sizes. So when you have trifurcation, this becomes, even more complex and challenging. So I think, however, that the concept of crossover stenting is very suitable also for trifurcation. The problem is that you need more manipulations to have a good result. Sometimes trifurcation is needed. So the only thing I do in my practice different is the fact that if I think that tristim balloon inflation will be needed, I adjust the size of the guiding catheter in order to accommodate those three balloons.
Yeah, thank you. Let's see the rest of the follow-up, Maciej, of your patient. It was simple primary procedure, and then?
Yeah, so we finished with the good result, acute result, but unfortunately, a couple of months later, the patient presented this time to our center with very severe crescendo angina precipitated by minimal exercise, and also she complained of some symptoms, chest pain at rest. And fortunately, she had a CD with the previous procedure. So actually, we knew what had been done previously. And this is, to our surprise, this is what we found on the angiogram. So you can appreciate that as for the LAD, there is a great result and no big issue as for the left main. But what we observed was actually now the ostial tight stenosis and some haziness at the ostium of the circ. So now we have another problem, completely different, because we have already stent at the ostium of the LAD, and something wrong is going on at the ostium of the circ.
Yeah, definitely. And I think this clarifies the importance of image guidance when we have isolated lesions of any of the ostia, LAD or circ, because guiding procedure, index procedure with the imaging will help you really clarify the extent of plaque, composition of plaque, vessel diameters. Our colleague Huma is asking, can you, if there is discrepancy in diameter of more than 1.5 or 2 millimeters, how should we approach left main LAD or left main circ? So please also answer that one. But I can say that now we need imaging in my perspective, and we need to understand what is the cause of this narrowing at the ostium of the circ. Francesco, anything to add? Would you do different?
No, I think that imaging is always a good option in interventions on the left main and bifurcation. This, if you didn't apply during the first round, I think that the second round is really something in which, a condition in which it is mandatory to apply. My comment is on what we see here. I think that the first operators tried to simplify as much as possible and to do not jeopardize the circumflex. And now we see that the undiseased vessel is tightly diseased. So this is probably very, representative of the complexity of the bifurcation in terms of disturbation of the flow that may change really the history. So what we do during one procedure may influence the outcome of the patients.
Yeah, our colleague is asking, is this new stenosis because of a plaque shift? Maciej, please proceed. You listen to us. You know the rest of the procedure, what you did.
Yeah, of course. So first thing is that you can clearly appreciate two things. One, left main is a very long vessel and free of disease angiographically. So that's the first point. The second point is, even at this image now, you will see that the left LAD stent is protruding just 1 or 2 millimeters into the ostium of the left main. So you are never sure if you want to be very precise with your stent positioning, that you will really hit the point at the very ostium of the LAD. One of the reasons is just the movement of the heart, which sometimes moves your stent a few millimeters. So that's the point. So you clearly see that the stent is protruding into the left main, and it was, if it were very, very early stage, so say days after procedure, we may have a huge problem with wiring this because you may get your wire under the struts of the stent, even into the towards the LAD. Fortunately, it's 9 months late, so everything was healed. But you can appreciate that the stent was protruding into the left main. So what we did the OCT. You see the LAD pullback. So what we found was some fresh thrombus in the proximal LAD at the takeoff of the circ, some organized thrombus exactly at the bifurcation, and the thrombus was protruding towards the circ. What you also see that the stent is healed, it's covered with tissue. There is no restenosis, no too much proliferation of the cells. So it was just a thrombotic event. I think triggered with the floating struts across the circumflex artery. And in the left main, what is also very important, in the left main itself, we did not find any significant disease. So this is a carpet view 3D reconstruction with OFDI image, just to show you that the stent is protruding towards, is covering the ostium of the circ and is protruding towards left main just a few millimeters. So now we have one thing we confirm that our LAD wire is inside the lumen of the stent, no outside the struts. Then we confirm that there's a thrombotic lesion at the ostium of the circ. And now, of course, it comes to make a decision how to treat this vessel, and we have two options. Of course, we could do the culotte, but we decided to perform a T or tap stenting. So you see the balloon ready in a left main LAD. You see two markers and the second stent positioned at the very ostium with some small protrusion, because we know that it's impossible to be very precise. So we have to protrude a bit towards the main vessel. After implantation, everything was followed by final kissing balloon technique with 3 NC short 30 balloons, and this is the final result. Very good result and good flow into both vessels. And we had an opportunity to check the patient. Actually, the first center, when the first case was done, checked patients another 9 months later, and this is the result.
Yeah, I think it's really fantastic result. But in the meantime, we received so many questions, and I think we have really a pleasure to discuss. Dr. Kartik is asking, what is the best way to nail the ostium in case of isolated ostial LAD lesion? Is there any specific technique that we would advise? And there is another question. Dr. Huma, can I please ask what is the cutoff limit to spare the ostium while stenting proximal LAD lesion? Is it 3 or 5 millimeters? Who wants to comment on this one? Is there any limit in your practice that you don't cover the ostium?
Actually, I think that there is no clear answer. It's not a matter of distance. The matter is, are you covering the from normal to normal, or are you leaving some plaque uncovered? And without imaging, nobody knows. I will show you some data shortly that in majority of cases, actually vast majority of cases, the LAD lesion is extending towards left main significantly. So if in most of cases, I try to cover, to put the stent as close to the ostium as possible. And if the lesion is ostial, I follow recommendation Francesco to cover left main also. So just to do the crossover stenting.
Yeah, there is another comment from Dr. Marcio Mossman. Did they post-dilate with kissing in the primary procedure? No, they just did direct stenting.
They just did very, very simple procedure, just 3-0, 15 stent puff, and that's it.
And Dr. Thanos is asking, any comment on the angle of bifurcation and decision to cross over or not?
Well, I can say that this is a very important point in my mind, because in the case of acute angle, we should anticipate the possibility to have some carina shift, even in the case we are precise with our ostial stenting. So I think that this can be another anatomical aspect that can allow us to consider or not considering the precise ostial stenting. In my practice, I really do not consider doing it in the case there is acute angulation, Sometimes, I mean, very rarely, I consider it when I have a very rectangular shape angulation, because we will have no carina shift anticipated.
Yeah, Francesco, maybe you can also comment on use after provisional use of FFR or IFR to evaluate functional significance of compromise of the ostium of the circ after provisional left main LAD stenting. Do you think there is a role in everyday practice to assess, or you simply kiss and then remove the struts?
So honestly, I work in a cath lab in which we use hundreds of FFR and functional measurements every year. However, the subgroup of intraprocedural ostial side branch stenosis evaluation is really the last subgroup we consider. The issue is basically the fact that we don't want to know if it is significant now, but we don't want to have suboptimal results for the long-term outcome. So I think that imaging is good as well, and this is our approach, so honestly.
Yep, yeah, but if I may add, there is one study by Korean guy Lee published in JAG Intervention 19. When they found that at 5 they checked the ostium of circ after crossover stenting, they checked with FFR, and what they found after 5 years that the low FFR group had a significantly higher rate of TV target lesion failure as compared to the high FFR group. So if they found that the FFR was below 0.8 in the circ, it's correlated with late outcomes. So perhaps that's the way to judge to check the circ after crossover stenting.
Yeah, thanks. Maciej, excellent questions for yourself, for your procedure. Dr. Spiridon Tsiamis is asking, tap through the proximal strut of LED stent, is it better to proceed with culotte? And second question from Dr. Madhu, when the LCX stent is deployed and you did final kissing balloons, the balloons would be in the left main, which is not stented. Is that a concern? So please answer both.
So why didn't we do the culotte? Two things: very long left main and no disease in the left main. So that's why we did not decide it. Of course, culotte was possible, and I think we could obtain very good result as well. The less metal to me is the better. So that's why we just with some protrusion, without avoiding that we are at the very ostium, without pretending that we are at the very ostium, because it's impossible. We did that. But of course, culotte would be a great option. And as for the kissing, this is always, tricky, but you do kissing many times after provisional, and you leave sometimes very large side branch or main branch non-stented. If you use imaging, then of course there is no big risk. And keep in mind that this left main was free of disease or minimal disease. What we did check with imaging. So I think it's very safe.
Yeah, another excellent question, Maciej, for you. Flores is asking if kissing would have been performed in the first procedure, it could have prevented the second event or not?
I think it will lower the risk, because you will get rid of all the struts covering the ostium of circ, and the flow would be better. And keep in mind that after some tissue proliferation, the occlusion or the jailing of the circ is getting more evident, so you have tissue covering not only strut but also some tissue covering so I think that kissing would be great idea, and perhaps you noticed that the doctors doing the case didn't even protect the circ with a wire. It was just direct stenting, and that was it.
Yeah, Francesco, you have experience with drug-eluting balloons, and Dr. Ali Al-Sulaimi is asking how to approach ostial LAD lesion that after stenting causes significant compromise of the circumflex ostium. Is there a role to do drug-eluting balloon inflation instead of just kissing with two balloons? You think there is a role for DEB in the index procedure or only at follow-up?
So we are still missing good studies regarding evaluating the use of drug-eluting balloon technology in de novo lesions in bifurcations. We have just small studies that have been also reviewed in the last EBC consensus. However, I think that in the case of restenosis in bifurcations, it really makes sense before adding stent struts to consider as valuable the drug-eluting balloon. However, in the case of side branch restenosis, which was untreated, I think that the idea of tap or culotte makes sense. So summarizing, drug-eluting balloon might be used. We miss actually data. For restenosis, we use mainly into the stented parts of bifurcations.
Yeah, Dr. Huma is asking, and I remember last year at EBC meeting, I have seen some recent articles on stentless treatment for isolated ostial circumflex lesion. What would you recommend about potential role of drug-eluting balloon only in such a cases? You remember Japanese series of atherectomy. So in large plaque burden, they were performing atherectomy and drug-eluting balloon with very nice result. And there is nice series of more than 100 patients done in multiple centers in Japan. What is your perspective on that one? We don't have atherectomy catheter available in Europe.
So my perspective is that we used in our lab atherectomy many years ago. And we noticed how operator dependent is and how complex is this kind of procedures. So I think that the Japanese group that provided this data are very experienced with that. I had the pleasure to discuss with them in a Japanese Congress recently, and I saw how fantastic was the result after atherectomy. So the drug-eluting balloon can be just cosmetic at the end. The problem is that it is really a challenging procedure with a lot of risks, so very, 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 very operator dependent and experienced operator dependent.
Yeah, because the key is to be very aggressive and to debulk the plaque completely.
Yeah. Yeah, yes. I like what Dr. Colombo says. Atherectomy does not work on intention to treat. You really need to cut and remove plaque. Otherwise, you cannot just put the catheter and take it out. I think this is a question which is good introduction for your slides again, Maciej. Dr. Hassan Kadim is asking, in treating ostial lesion, always we are expecting some strut protruding, especially the lower part of the stent. How can we avoid this from the start? How to prevent protrusion and compromise of the side branch as well?
Yeah, the only way is to just to cover the whole thing, you know. So I will just show you some data. This is a very nice study published 11 or 12 years ago by Alfonso Medina and his group. 71 patients with ostial LAD lesion stented with drug-eluting stents, and I was 70% of patients. So they call it the floating stent technique. So this is exactly what my colleagues from other center did with the lady I presented. So as you see, they use IVUS quite a lot, 70%. And they found that there is a very clear predictor of side branch compromise, which is the vulnerable shape of carina. And they call it a spiky carina or eyebrow sign. So if you see a very spiky, sharp carina, which occurs mostly in the narrow angle bifurcation, then the risk of compromise was high. When the carina shape was blunt, not very spiky, then they could obtain very good results. So that's one of the example where there were no this vulnerable anatomy. And the result, as you see, with just ostial stenting with deliberate protrusion of the side main vessel stents or LAD stents into the left main, the result was quite good. But a few years later, another study was published, and actually the authors observed 74 consecutive patients treated for ostial LAD with just ostial stenting, 38 patients, or crossover, left main crossover. Interestingly, IVUS was used in most of 50% in a crossover group, but only in one patient with just ostial stenting. And of course, the stent diameter was larger for crossover because they post-dilated. They did a pot in the left main. What they found, and this is really very important, that angiography will not tell you about the real plaque morphology. And they found that the IVUS revealed a significant extension of the plaque towards the left main in as many as 86% of patients. So it really occurs very, very often. And they then observed the patients for 50 months, so it's around 4-year long follow-up. And they found that in the ostial stenting, the MACE were doubled. And you can also see that cardiovascular mortality was doubled after 4 years in the ostial LAD stenting group. And TVR was significantly lower. Actually, a TVR occurred 4 times more often in the ostial stenting group as compared to crossover group. You see that crossover group, there was only 1 case of restenosis and 0 stent thrombosis. So I think that we are very often, doctors are very often afraid of, they are scared of stenting left main in just LAD ostial lesion. But here you see that this procedure is very safe, very effective, only 1 restenosis, and very safe because there is no stent thrombosis. So I think that this table and this work is a very nice explanation and confirmation of and recommendation for crossover stenting instead of trying to position a stent exactly at the ostium of the LAD.
Fantastic. Thank you, Maciej. 2 questions for you. Dr. Ostrichki Branko is asking, what do you think about drug coating balloon only as the initial procedure of ostial LAD?
Yeah, I think
that's a viable option, yeah.
We are on the verge of a big trial with which will maybe show that we can replace many stents with drug coating balloon. The one thing is we don't have a very efficient device for now, and the other thing, we are always afraid of of dissection and early and late complications. So I will call it a provisional stenting in terms of doing it with the drug-eluting balloon and stent if needed. Yeah, so I think this is a good option. The only thing is that the ostial lesions are very often very fibrotic or calcified, and the recoil may spoil the result of the procedure. Not the restenosis, not proliferation, but just the recoil.
Perfect. And Dr. Thanos, the last question for you. Do you consider the findings of OCT as a restenosis or thrombosis? If it was just a thrombosis, why new stent and not just kissing, less metal?
Yeah, that's a good question. It was mostly a thrombotic lesion. It was mostly thrombosis. Perhaps we could try to open and do the kissing and open the circ and leave it like that. Especially having imaging OCT. So that's a good idea, and I think that it would not be a mistake to do like you suggest.
Yeah, perfect. So Igor, can we conclude that the better, more safe option for ostial LAD lesion is left main LAD stenting, even if left main is free of disease? I think we answered that one. But let's talk about ostial circ. Prof, Burzotta, please share your case.
Yes. So the case I want to share is a young, 50 years male with familial history of ischemic heart disease at a young age, father death at 49 years due to MI, uncle receiving cabbage at 53 years ago. Then he was a past smoker and he had hypercholesterolemia. Cardiovascular history was since October 2019, he had a typical chest pain during emotional stresses. So on November 9, 2019, he had echo assessment, which was normal, and exercise ECG showed minimal ST depression during recovery phase. Thus, he received CT scan showing diffuse atherosclerosis, non-significant distal left main lesion, and tight and soft ostial circumflex lesion. So with this condition, he went to our cath lab. This is the right coronary artery assessment. You see some diffuse disease with but no tight stenosis. And this is the left system showing on the left diffuse disease inside the LAD proximal, and a tight disease into the stenosis into the ostial circumflex. After nitrous, this is the lesion apparent inside the ostial circumflex. And I think that here it is really, difficult to take this kind of decision. First of all, it is not a common finding, something like that, short lesion in this young man. So I would like to hear about your approach, because I was not so happy to find something like that.
Maciej, would you like to start first?
Yeah, of course. This is, the ugly lesion nobody likes, because left main and LAD looks pretty normal, and the angulation is it's a narrow angle, so we can all expect that there would be some pinching of the LAD, which nobody likes. And on the other hand side, using two-stent strategy is also not good, because we will cover with metal a lot of tissue and vessels unnecessarily. So I think this is always a big question. As for the nitrates, I think that's the first that occurred to my mind. It's really important to if patient tolerate to add nitrates, sometimes twice or even more, especially for ostial left main. I remember a couple of issues when after 3 or 4 times every nitrates we give the vessel grow. This of course looks atherosclerotic, so definitely needs treatment. So protecting LAD, pre-dilatation, and then upon the result of pre-dilatation, perhaps just one stent from the left main to the circ.
Yeah, I would agree 100% with all that you just said. And I would like just to introduce for people who attend this webinar, when we speak about provisional, we actually speak about stepwise layered strategy. So when we say provisional, we don't decide from the beginning if it's one stent or 2 stents, because we put one stent towards the disease side branch, in this case circumflex, we optimize result inside the left main, and then we evaluate after POT, is it acceptable or there is compromise? If we need to do more, we do kissing, LAD circ, and then we evaluate again. Should we stop here or we need something more? If we need something more, then we add second stent into the LAD. And all these steps are different layers of complexity which we are adding, and it's still provisional. It's provisional if we stent left main LAD, it's provisional if we stent left main circumflex, it's just inverted provisional. So Francesco nicely wrote that, and we put it really in our consensus document just to share with the community the importance of understanding that provisional does not mean single stent. Francesco, you are the first author. Please elaborate briefly on that one, because people frequently ask if provisional is single stent strategy.
No, I mean, we really do not think this, and we know that in the concept of bifurcation intervention is the fact that the operators should have a plan, and the plan cannot end most of the time with just putting a stent. We should appropriately select the stent, appropriately manipulate the stent with ballooning techniques, and we will probably review during this case. We started with the first case. Moving forward, I have to tell that we didn't mention medical therapy. I think that in my practice, I often decided not to treat some ostial circumflex in the case the patient is stable, or in the patient, if the patient is old. I mean, I'm not expected to have a really lot of efforts testing the possibility to have ischemia. And in the case of doubt, is really the condition in which we like to assess the need for intervention with functional evaluation. However, in this case, the patient had positive stress test, it was symptomatic, and it was very active. So into the planning, we mentioned before how important can be assessment of the lesion by imaging. I think that when we perform imaging, we should have questions for the imaging. And so what we did was first to image LAD. Why? Because there was some diffuse disease inside the proximal LAD up to the mid. We didn't want to leave untreated lesions over there. And you see here in the bottom with the long axis reconstruction, you see that there was disease not compromising the lumen. And you have also the cross-section that was assessing the ostium of the LAD. And this is a very important point, because we want to know if there is tight disease. Sometimes we may discover the fact that there is important plaque first. Second, we want to know which is the size of balloon eventually needed for kissing, who are less able to create the risk of dissections. So in this case, we took the lumen measurement to select the balloon for kissing done after. Second evaluation was done into the circumflex area. You see that due to the tight disease, there was imperfect visualization of the lumen. However, at the ostium, we have been able to show that there was a tight organic disease, quite circumferential, and we have been also able to evaluate the size of the distal circumflex to use as a landing zone. And we noticed that there was another plaque beyond, so a longer stent as was needed. So on top of this, we went on according to what we said. I mean, we have reviewed in the updated MADS classification the possible interventions. And we now clearly emphasize the fact that provisional can be done according to inverted provisional. And after having implanted the stent, we have multiple options to accommodate the stent, adapt it to the different sizes, and eventually to implant a second stent in the case of need. So what we did was to predilate the tight ostial circ lesion with non-compliant balloon sized 1:1 according to the size of the vessel we want to treat. So very aggressive dilation. Why doing this? Because under expansion at ostial lesions is often the start of restenosis. So we dilated it properly. And after that, we checked that there was no measure plaque shift toward the LAD. So, and you see into this shot that it wasn't. So after that, we implanted the stent according to inverted crossover. You see that to deliver the stent, we came finally into the cranial view in order to reach the proximal part of the left main. We do it most of the time. We don't want to have into the manipulation that will come after the risk of geographical miss, having dissection at the edge of the proximal edge of untreated ostial left main. So the stent selected was 3.5 by 38 according to imaging, and this is the phase in which the stent is delivered and at nominal pressure, and you see that the stent is well expanded. After that, we took this shot. I think that this is very important because here we have a very, very important side branch, I mean, LAD, and we don't want to have an occlusion due to plaque or carina shift that is not recognized. And at this stage, it is important to see if we are still in line with good flow to LAD. In the case if we have a problem, before performing POT, is very easy to advance a balloon to restore flow. I think that it is very important advice for people that is afraid about losing LAD in the context of inverted provisional here. So after that, we performed the POT with a balloon which was sized according to the OCT reconstruction, and we selected a semi-compliant 4.5 that was repeatedly expanded, first at the distal part at the carina, and then coming back high pressure to have very good apposition and expansion at the ostium. And everything was checked in order to have no malapposition during the further interventions were coming. After that, we aimed at performing kissing balloon inflation. Kissing balloon is intended here to remove stent struts from the ostial LAD, but we know that the effectiveness of kissing balloon is highly dependent on the position of rewiring. So what we did was to keep attention during rewiring to go very distal, and to do this, we advanced a third wire first into the distal circumflex, and then we came back step by step till the wire got inside the LAD. At this stage, you see here, there is angiographic injection. Why? Because we want to check in good projection if the radiopack part of the rewiring is very distant. We were happy with that and with this situation, so we moved forward, and to perform kissing, we went with two balloons, and we practiced. We selected the short non-compliant balloon and performed it in a sequential way. So, according to this, the two balloons are placed over there. Then, non-compliant balloon has been expanded pressures into the circumflex. Then, the non-compliant balloon selected according to OCT lumen was expanded inside the LAD. And then the kissing was performed at 14 atmospheres, and the semi-compliant balloon for pot was repeated. So this was the sequence we applied, and this was the result for LAD, which was unaffected. And this is the result into the bifurcation area. You see that really is we didn't jeopardize the LAD ostium. We also checked by OCT into the circumflex, and with that we have been able to see that there was no dissection at the edge. There was optimal expansion at the ostium of the circumflex, and there was at the carina level no signs of dissection at the ostium of LAD. You see very well here. Then the left main was very well expanded. So we have been satisfied with that. The clinical course was uncomplicated. The patient was discharged the day after with no CT and B release, and he came back to normal life. So this is the history of the patient, but we want to look into the follow-up. When we have left main treated by single stent, we are using more and more a CT scan because the number of artifacts is limited due to metal. And so this patient underwent CT scan 14 months after. This is the bifurcation with some calcium, but fairly patent both vessels. And here you see that the stent was well placed and with optimal expansion and patency. And it was also possible to appreciate the ostium of the LED, which was very nice. So this is the case I want to share. And I think that this is really, rare to apply it to circumflex, but basically we did all we do routinely for LED ostium.
Perfect. Thank you very much, Francesco. Really very nicely documented with many questions coming from you. For you, please try to answer very precisely. And we start with Mahmoud. How about cutting balloon initially instead of putting stent? And again, Huma, would you consider drug-eluting balloon only, considering that LAD has disease already, which can progress, and ostial stent in circumflex may compromise future access to LAD? So cutting or DEB, did you think about that?
So I think that cutting could have been used in my procedure in the case there was no expansion of the non-compliant balloon. You saw that we aggressively used the non-compliant balloon. Next step in the case of node expansion could be cutting balloon. Regarding the possibility to perform cutting and drug-eluting balloon for side branch stenosis, we already discussed. It is something that is theoretically interesting, but we are lacking scientific data. So we are there to drug-eluting stent technology, actually.
Perfect. You selected stent, and we have Dr. Manukian, and we have also Dr. Milan asking, would you always come back to left main ostium in this scenario, or would you ever finish in the body of the left main if it is normal and long enough?
So I think that the argument for covering the left main ostium most of the time is the fact that we don't want to have geographic miss during the manipulations we know are anticipated during a procedure like that. I mean, POT was needed. In the case you are not precise, you may have a bottleneck effect, so undilated the proximal part, or you might have some dissection or geographic miss. So most of the time we like to cover. Just in the case of very long left main, we avoid to cover it.
Okay.
Perhaps one additional comment. There is also some contraindication to stent the whole thing, the whole left main, because if it's very long and you cover the ostium, you increase the risk of abdominal wiring and stent damage. So stent deformation with your guiding catheter. So also keep in mind that be very careful when you cover the whole left main.
Yeah, for sure. I think that we with really good reasons promote use of imaging, but Igor is asking, would you do the inverted provisional in this case in case you don't have IVUS or OCT? So is the imaging mandatory if you want to do crossover inverted fashion?
Honestly, I think that it is really something that increases the flow of your procedure and helps you in accepting the result as at the end. However, sometimes I did in the past without imaging.
Okay. Martin is asking you, Francesco, 3.5 stent nominal pressure and then 3.25 kissing. Is that a mismatch?
So for kissing, we selected the balloon according to the OCT lumen measurements, and so I think that it was between 325 and 3.35. We prefer to go very high atmospheres with the 3.25.
Yeah. Is anyone of you aware? Mauricio Mossman is asking, are there trials considering treatment of ostial circ as ostium of the LAD? Maciej showed some data for the ostium of the LAD. We don't have such trials for the circ.
No randomized trials, no randomized, only observational trials.
Yeah. So if we try to summarize today's discussion, and we intentionally selected both isolated ostial LAD, isolated ostial circ, just to share the practice and actually strategy that we apply in a similar fashion in both. So I would like to ask both of you to quickly summarize your approach in daily practice before we conclude the session.
So if I may start, to me, as you mentioned, provisional is not the technique, it's philosophy. So when you start with provisional, you have a lot of options, and you may have a lot of plans how to do the procedure. And for me, for any ostial disease at the side branch, regardless whether it's circumflex or any other, inverted provisional, exactly the way Francesco presented, is the default strategy. So even if I don't use ultrasound, or even I don't use imaging, I do not hesitate to do the kissing and to touch with the balloon the main vessel. And as long as the flow is good and there is no compromise and no significant stenosis or dissection, I think that this is the way to go. And another issue is ostial left main, and then I recommend upon this case and also other my cases in my daily practice, I strongly recommend covering left main and the LAD, so crossover stenting, but of course with adaptation, with respecting the fractal geometry, POT, kissing to remove the struts from the ostium of the circ.
Francesco?
So on my side, I mean, I showed the fact that we push our provisional to even for circumflex. So I think that for LAD is our default strategy. For ostial lesion, we didn't explore too much during these cases, but I think that we should also afraid about the possibility to expand properly the stents. So most of the time, it is very advisable to predilate aggressively the ostial lesion when we are outside acute conditions. So if there is a stable plaque, most of the time that can be calcium, and if a way to skip imaging can be the fact that we routinely predilate appropriately, because at the end, to have the problem of the bifurcation and the under-expanded stent is a mixture that we don't want to have, and ostial lesions are often stiff.
Francesco, last question for you. I think it's very important. Mark is asking, what if there is a big difference in diameter between left main and circumflex? Would you do the same?
Honestly, is to know very well which are the expansion limits of our drug-eluting stent is very, very important in this kind of procedures. This is why in the BC consensus, we also put a table regarding left main, we put a table with the expansion limit of the stent, and we should know this. Let's remember the fact that most of the stents can be expanded even more than reported on the instruction for use. So this is another important feature. And the last thing is the fact that when we have ostial lesions, the issue of poor coverage that is associated with the overexpansion of the stent in the left main is less important, because plaque prolapse cannot occur because there is no much plaque if it is really a 0, 1, 0. So most of the time I accept the fact that I will overexpand the stent a little bit more.
Okay.
Last thing is the fact that we may also consider using under deployment technique, but it opens other issues, so I don't want to cover too much.
Thank you. Can I have my conclusion slides? So we discussed today 010 and 001, isolated ostial LAD and circumflex. These are unfavorable for PCI because of technical difficulty and risk of complication. However, with branch ostial disease, there is frequently involvement of distal left main, and thus the risk of incomplete coverage is reduced by stenting crossover into the left main. From this perspective, left main branch ostial lesion is necessary bifurcation lesion and should be treated similar manner. Next one. Provisional crossover stenting from the left main into diseased branch is recommended for both isolated ostial disease of LAD and the circ, and imaging guidance is strongly recommended to assess plaque burden and distribution before deciding the technique for each specific region. I thank you very much to all people who followed us. I thank you for sending your fantastic questions. I thank you, of course, my colleagues, Professor Maciej Lesiak, Professor Francesco Burzotta. I learned a lot from you. I enjoyed discussing with you. And I would like to thank, of course, Medtronic for supporting this series. And we are planning already next webinar, and we hope it will come soon. So follow us on Twitter, and thank you very much. Please send your proposals, what kind of webinars on bifurcations and left main you would like to attend next year. Thank you very much and have a good day.
Thank you so much. Bye-bye.